Okay. So we'll talk a little bit about protocols and about congenital disease, osteonecrosis, trauma, infections, and then we won't talk much about neoplasia on this go round. We typically use 6 acquisitions for hip imaging. We use a large field of view T1 and stir in the coronal plane so we can see both sides. I think that's important. A lot of people don't get large field of view to see the other hip, but I think for a lot of things, including, as we'll talk about, the importance of the gluteal muscles and tendons, symmetry is something that's, I think, really needs to be evaluated. And then a large field of view axial PD fat sat. And then we do 3 small field of view images, one in the sagittal plane with T2 non-fat suppressed, a small one in the coronal plane with PD fat sat for higher resolution to look at the labrum and the articular cartilage, and then an oblique axial. It says T1 or PD fat sat. Now with the current scanners, we typically do PD fat sat and not T1 in the oblique axial plane. And this just shows the plane that we do the oblique axials in, and we'll talk about why later on. Now, one thing about the oblique axials, this is what a T1 image typically looks like. We tend to have less problems here. On PD fat sat, for a while, we were having troubles because it was hard to get reproducible image quality. And then what we can see here is a lot of kind of blurring. But if you look, that blurring is kind of in a line along here, which comes from the vessels. If you change the acquisition in the same patient so that the phase encoding is anterior-posterior, you find that that flow artifact from the vessels projects anterior and posterior, not over the hip. And once we recognize that and switch the AP, we could get reliable oblique axial PD fat sat images. So just remember, if you're having trouble, check the phase encoding and make sure you're not getting phase artifact into your images. And we still occasionally do MR arthrography of the hip. Some people feel that there's some advantage to that in the hip, where there's much less advantage in the shoulder, but that's somewhat controversial. Okay, and then neoplasia, basically whatever is necessary. Okay, Robert, here's a patient who came in, had a history of a resection, a sarcoma resection, right in through here, and this was to evaluate for recurrent disease. What do you think about this T1 pre and the T1 fat sat post contrast images?
Well, I would have liked a pre-contrast T1 fat set to be able to compare appropriately.
Good. Yeah, you're brainwashed here. So we can see here, as I've said over and over again, I just can't emphasize it enough. Um, uh, Many times outside images, this is what I'll see. There's no pre-T1 fat sat post. A lot of tissues will be bright on a T1 fat suppressed image that aren't bright on the T1 image. And if you go back and look at this is the T1 fat sat post. Here's the T1 fat sat pre, and you can see those tissues are very bright, and there's no enhancement here. If you don't do the T1 fat sat pre, you'll have a lot of false positives, which can cause a lot of consternation, especially if you're dealing with neoplastic disease. When you tell someone that they have recurrent disease when they don't, that can be a real problem. So I think again, I've said it before many times, one of the biggest repetitive problems that I see in musculoskeletal imaging is that a lot of people will not spend the extra 1 or 2 minutes of time to get a T1 fat sat pre to compare with a T1 fat sat post. You have to have it if you're going to look for contrast enhancement. Congenital disease. Taysom, what do you think is going on here?
Looks like there's a defect going through the neck of the
Yeah, so this is this is called focal femoral deficiency, and it's usually a congenital problem. I mean, you always have to think about whether there could be an old fracture that went on to a non-union, but this constellation of changes are often congenital. Okay.
Okay, long-standing hip pain. In the right hip, we see, well, both sides really, but under coverage of the superior acetabulum, some superior subluxation of the right femur.
Right. Worse on the right than on the left. And we'll talk about some of these angles in a minute here and things to look for and even occasionally measure. Right. But this is congenital dysplasia of the hips with undercoverage. Right. Robert.
So here we have a 36-year-old female with bilateral hip pain. Again, it looks like there may be some acetabular undercoverage.
Yeah. So undercoverage. And then if we typically do this by measuring the center edge angle, I'm going to go through these in a minute. This is very abnormal. I'll go through what the normal numbers are in just a minute. So this is developmental hip dysplasia, often get a high riding hip and so forth. And then it's what you can see if you have dysplasia, the forces that go through the hip go through a much smaller area here. The weight-bearing forces that should be distributed over a very large area, but when you have dysplasia, it's over a very small area, and this predisposes to increase pressure in this area and destruction of the articular cartilage and degenerative joint disease. So let's talk about radiographic measurements. So there are a number, here are 5. These are very common ones that you need to know about. One is the center edge angle, which is the angle between a vertical line going through the femoral head center and a line tangential to the lateral margin of the acetabulum, just what we showed on that previous image. Normal is greater than 25. Borderline dysplasia is 20 to 25, and dysplasia is less than 20. What's not shown here that I'll show in a minute, somewhere here, I think. Anyway, if it's over 35, then you've got over coverage, which is another problem that we'll talk about. Then there's a vertical center anterior margin angle. It's really from the lateral false profile image, and you can look at this on the sagittal MRs. Let's see if I have an example of this. So this is the center edge angle. This is a normal center edge angle if you do it on AP images. And here's abnormal. That's way too small. And here, this is under coverage as well. So the vertical anterior center margin here, an oblique image, you can do a vertical line through the center of the head and go to the anterior margin of the acetabulum, and this should be around 19 degrees. I don't use this very much. It's also not a projection that we really do with MR. The third one is the femoral head neck shaft angle that you're all familiar with. This is evaluated for coxa valga and coxa vara. So I usually just eyeball it, but if I think that it's abnormal, then I go ahead and measure it. The one thing to remember on an MR examination is that often the proximal femur is somewhat rotated, and then that our coronal images may not actually be through the central plane of the proximal femur. And if it's rotated a certain amount, you may get some deformity in the measurement. So you have to kind of eyeball that on yourself, and then you can measure. You take a line that's drawn right kind of in between in the center of the intertrochanteric region, a line going through the long axis of the neck, through the head, and a long axis of the diaphysis here. And this angle is the head neck shaft angle. Normal is 120 to 135. Coxa valga is greater than 135, and coxa vara is less than 120. And obviously, if you coxa vara, you've got abnormal pressure. In this particular case, you've got marked instability of both hips, but it causes abnormal pressure distributions if you don't have the correct angle. Another angle that the hip people are interested in is the tonus angle. And if you go back to those congenital cases where we had undercoverage like we have here, well, what the tonus angle is basically if you draw a line through the top of the sorsal here and go to the margin of the acetabulum, and then you draw a line from the sorsal horizontal across here, it's this particular angle. And this should be, most of the time, the tonus angle should be less than 13. It's dysplastic if it's greater than 13. And here, this is very abnormal. And if we go back here at here, we can also see that if we actually draw the tonus angle here, this one would probably be close to normal. Here, this would be very abnormal. If you draw a line here and then a line up through there, that tonus angle is going to be greater than 13 degrees. So this would be abnormal, and it's abnormal on the left side as well. Yeah, that just shows, again, that if you have forces between the femoral head and the acetabulum, if it's angled like this, you're going to get more of a kind of a tendency toward lateral displacement of the head when you put weight bearing. So the tonus angle is something that the surgeons will often want to evaluate before they try to figure out what to do with hip problems. And then another one, you can measure the position of the fovea alta measurements, where you take a point in the center of the femoral head, draw a line to the top of the fovea, and I'll line up to the edge of the sorsal, and you can measure this particular angle, and it should be normal is greater than 10 degrees. That's not one that I typically use. And there are a bunch of CT measurements that you can also use to evaluate the hip and so forth. These I use less commonly with MR. But there's the anterior acetabular sector angle, posterior acetabular sector angle, and the horizontal acetabular septa angle. But I really I don't use these routinely. Okay. All right. I don't remember who's next, but there you are.
Okay, 33-year-old runner with hip pain. Is there edema on the inferior aspect of the neck?
Yeah, right in through here.
Mm-hmm.
Through here. And if you look at this, it may have a little bit of coxa valga as well.
Okay.
This would be a case where I'd make the measurement and see what the angle is. And this is a congenital stress injury. And again, when you have coxa valga and coxa vara, you're going to get abnormal stress patterns if people overuse the hip because you're not in the optimal functional angle. So, and again, it's just examples of coxa vara norma and coxa valga. Robert.
All right, so we have a 3-year-old male born 34 weeks premature, and both the femoral heads look underdeveloped and dysplastic there.
Yeah, here's what the MR looks like.
Yeah, pretty similar.
Yeah, and this is called coxa magna with dysplasia, and obviously there's bilateral coxa vara here in this particular patient.
All right, 8 months low back pain for 1 month.
8-year-old male, low back pain for 1 month. Okay, there are the X-rays.
Okay.
There's the MR.
Yeah, is there
So
some sclerosis at the growth plates?
yeah, there's a little sclerosis, some irregularities.
Yeah.
Yeah, and on the MR, there's a lot of irregularity of the growth plates, a little bit of flattening of the articular surface. And this is a patient who had epiphyseal dysplasia,
Mhm.
and there are many different types of dysplasia. This was called the Myers dysplasia, and really just when you see abnormal epiphyses like that that are irregular, then kind of put it in that category.
Okay, 20-year-old after trauma. Um, hmm. Okay, well, on the right side, there's this bone extending inferiorly from the sacrum. Hmm. Yeah, deformity of that sacrum and lower lumbar spine. Yeah, it looks like there's a cleft in the posterior elements. Yeah, I'm not sure.
Yeah, this is one of the appearances that you can get with sacral agenesis, Currarino syndrome. And it can be associated with the different kinds of neurologic dysfunctions. Okay, Robert?
All right, so we're looking at the hip here, and it says, "What is this?" Not entirely sure what we're looking at here, but I think it's just the posterior joint space and some thinning of the cartilage there. But
Yeah. So, right, we're seeing this joint space here. Yeah. Oh well, forget that's okay. So let's go on and talk about osteonecrosis. So osteonecrosis is really defined as if yeah, in the old days, a lot of bone problems were infections, especially in the pre-antibiotic era. So the major cause of osteonecrosis was actually infectious disease in those days. So uh, once antibiotics were developed, then the concept of aseptic necrosis developed, which is really marrow cell death from anoxic or toxic injury, as opposed to cell death from infection, which was the common thing before. Now, the three stages of cell death, initially, if you have a toxic agent or cells don't get oxygen or nutrition, you get interruption of the enzymes, you then get alteration of metabolism, and if that's severe enough, you'll get destruction of the ultracell of the internal structure of the cell and cell death. The timing of cell death depends upon the type of cell it is. It's relatively rapid in hematopoietic cells, 6 to 8 hours, and osteoclasts and osteoblasts, it's a little bit longer, up around a day or two. Fat cells can last for much longer. So avascular necrosis can be associated with a number of factors: trauma, especially if you interrupt the blood supply to the bone, hemoglobinopathies, drugs, steroids, alcoholism, dysbaric disorders, pregnancy, collagen vascular disease, and pancreatitis are common ones. Now, there are phases of cell death and their appearance on imaging of the femoral head. So you can get cell death. And initially, if you get cell death, basically you don't see anything on imaging. But then what happens is that the internal molecules within the cell, once they become extracellular, they are picked up by macrophages, and that starts an inflammatory reaction. And then you get inflammation in the area to try to mop up the debris and contain the damage. And what you'll then end up with is a reactive interface, which occurs between normal bone tissue and abnormal tissue with the cell death, this reactive interface. And this is something that on MR imaging helps us be much more specific at making the diagnosis of avascular necrosis when we see this. And eventually, what happens is you have weakening of the trabecular bone and the bone structure, and you get remodeling of the bone and eventually articular collapse. So if you have cell death initially, if you do not have a host response, then you'll have a normal MR scan, MR findings. So very early on, you can have a normal MR. Once you start getting the inflammatory stage, or if you get a trabecular fracture with it, you'll see marrow edema, typically in the subchondral bone. Once the reactive interface is established, you'll get a ring sign, or the double line sign that we'll talk about, which is considered highly specific for avascular necrosis. And then later on, you'll get fat cell death, where you get kind of a homogeneous abnormal appearance on a T1 weighted image, and then structural loss with subchondral fractures, and then you go on to collapse and degenerative disease. Pain correlates mostly with the marrow edema, and we'll talk about the different stages, and that typically occurs in Steinberg stage 3 and is really associated with subchondral bone fractures as the most painful area. Now, there are a number of different classification systems for AVN of the hips. The Ficot-Arlet classification is a common one, primarily developed for X-rays. And these are the different stages, 0 through 4. So symptoms, you tend to get pain very early on. X-ray may be negative, MR may be negative, or you'll see bone edema within the femoral head. Stage 1, you'll also get pain. You'll start seeing the density changes within the subchondral bone on X-ray, and you'll get bone edema with an intact subchondral bone at stage 1. Stage 2, you continue to have pain. You see sclerotic changes on an X-ray with a subchondral bone looking intact, and then you still have edema on an MRI. Stage 3, you have pain and mechanical symptoms within the knee of clicking and locking and so forth. On X-ray, you get sclerosis, you get loss of the spherical shape, and you can develop the crescent sign, which is an X-ray subchondral fracture. And on MR, we see subchondral fractures. And then stage 4, pain with mechanical changes, you see bone destruction on X-ray and severe degenerative disease on MRI. And there's the Mitchell classification, which isn't used that much anymore, but in the early days of MR, had stage A, B, C, and D, just defined by T1 and T2 findings. This was created before we had PD fat-sat images. So initially, you could get an abnormal signal on a T1, loss of signal. T2 is normal. Then you get abnormal with both. And then finally, the T1 looks more normal, and you get edema on T2. Or low signal, on T1, and then finally you get low signal intensity on both when you get fibrosis and chronic degenerative disease. But the classification system that I think is most useful is the Steinberg classification. But again, in my reports, I really don't use any of these. I just basically describe the findings. And again, like everything else, there's so many different classifications that you have to be very careful how you word it so people aren't confused about which stage you're talking about depending upon which classification system. So stage 0 is where you have no symptoms, negative X-ray, and you only have a positive MR. At stage 1, you can have a normal X-ray but a positive MR. Stage 2, you see cystic and sclerotic changes on an X-ray. Stage 3, you have the crescent sign or the subchondral fracture. This tends to be, as I said before, the most symptomatic stage. Stage 4, you get more flattening, joint space narrowing, and then finally advanced degenerative joint disease. And then there's the ARCO staging system, which is uses MR and X-ray. There are some individuals, I don't know exactly how they did the study to do this, but they had no symptoms, negative MR and X-ray, but they had osteonecrosis on, I guess, a biopsy. I don't know how they would do that particular study. Stage 1 may or may not have clinical symptoms, normal X-ray, positive MRI. Stage 2, symptomatic trabecular changes on X-ray, positive MRI. Stage 3, symptomatic subchondral bone fracture on both studies. And then stage 4, symptomatic altered shape of the femoral head. The one thing I'd like to come back just for a second in terms of the subchondral bone fracture, as you all know, MR is much more sensitive to detect this than plain films. So again, I would, if I do grade it, I really think the X-ray grading system is not very accurate because it's just not sensitive enough to pick up the findings. So if you do grade it, I think it should be graded with MR rather than X-rays. So let's just look images, typical normal study. These are old scans, but pretty typical. T1 weighted image and PD fat sat images. You tend to get a lot of fat in the femoral heads, and therefore you can see a fat suppression typically in femoral heads. T1 and T2 images you're all familiar with. Early abnormal findings on the T1 weighted image, you can see loss of signal, which is consistent with edema within the bone, where you're losing the fat signal within the bone. So this would be stage 0 to 1 using the Steinberg classification. Something else that Dr. Tierman likes to talk about is the absent edema sign, where in this case you see bone edema here, should have edema all through here, but in areas where you have loss of the vascularity, you may have a delay in developing edema. So you'll see areas of edema with a lack of edema in the central area, which indicates poor vascularity to that central area, which is characteristic of also of avascular necrosis. And then I really don't like to use the term avascular necrosis in an MR report unless I see the double line sign. Here we can see a typical serpiginous margin of this lesion, which is really kind of has to do with the margin of the vascularity of the medullary bone. And here we can see the typical double line sign, where we see a bright linear signal on one side and dark on the opposite side. There's been a lot of debate as to what produces this signal. It's fairly frequently seen on one side, but not the other. So many people think it may be a chemical shift phenomenon, which does this. But this is the double line sign. And being in a serpiginous pattern like this is considered pretty pathognomonic of avascular necrosis. Here we can see someone who had pain more on the left than on the right. This is the sagittal through the left side, and this is what the crescent sign looks like on a T1 weighted MR. This is really a subchondral fracture. And again, what this is due to, you have AVN that's developed in the bone here. Therefore, you don't have proper nutrient supply. The osteoblast and osteoclast can't remodel the trabecular fractures that occur, like we talked about in the bone lecture, how the body remodels the findings. And it's essential. You get cracks in the trabecular bone everywhere in your body all the time. You have osteoclasts that come by to remove that bone, blasts that come over and basically seal any cracks. And so your body is continually healing microtrabecular fractures through your body all the time. If that process stops, then those microfractures are able to coalesce into larger fractures, which can lead to symptomatic fractures, and that's what happens in these areas where you continue to have weight bearing through the subchondral bone of the femoral head. You no longer have the ability to remodel and repair the microfractures. They coalesce into a macrofracture, and you get the crescent sign of a subchondral fracture. Okay, Jason, what do you think of this case?
All right. So it looks like we have a lot of edema in the femoral head, and there's some collapse of the subchondral.
Yeah, and then we have
bone.
this funny kind of margin. It looks almost serpiginous on the
Yeah.
margins, but we don't have that sharp delineation of the double line sign, but it's kind of trying to give it to us. If we go to the sagittal images, what we can see here is This is a subchondral fracture. This is a crescent sign, and this is more of a double line sign with a serbiginous finding. So this is a patient who had AVN, who had a subchondral fracture and was symptomatic.
Okay, so here with IV contrast, we see a similar serpiginous pattern bilaterally.
Yeah.
Is there enhancement? I don't think there is.
We don't know because I don't have a T1 pre, right?
Oh, right. Okay.
This
That's
is
the
PD
PD fat set pre. Okay, yeah.
So we can't tell whether there's enhancement or not. Here's
How
a T.
often, I'm sorry, how
Right.
often do you have bilateral
Bilateral AVN.
AVN?
Okay, you wanna answer that?
I think,
50%,
well, what was that? 60?
50,
50. Okay.
50.
Okay. All right. Here are the sagittal images again showing that serpiginous margins.
I'm sorry to interrupt you, John. You don't necessarily see it at the same time, but you have one hip you diagnose, and then 5 years later you diagnose the other hip if the patient doesn't behave the way they should. And of course, trauma sometimes will give you bilateral subcapital fractures, and that's a different condition than what we're talking about right now. Same kind of process, AVN type of process, but it's obviously a fracture, not what we're talking about here.
Okay, thank you. Okay, here's a case, and here we can see a focal area of subchondral bone that's abnormal. We see what really looks like a double line sign on the T2 sagittal images. These are very old images before PD fat set were available. What I want to put out here is that you can sometimes see a very homogeneous appearance to the fat. And early AVN where the fat is still there, but it's really not normal. It doesn't have the normal texture to it that the other fat has. And this is also avascular necrosis on this particular femoral head. Robert, what do you think about this?
All right. Looking at the right hip, there's a lot of loss of the normal T1 signal there and irregularity of the contour of the femoral head. And then also on the left side, it looks like there may be a early double line sign there.
Right. So these are two different stages in the same patient. Here we can see this is very far along. We actually have subchondral collapse. So this is basically the end, close to the end stage of avascular necrosis. This is inverse. This is very early, where the subchondral bone is still intact, but we can see the evidence of avascular necrosis here. So this is a stage 4 on the right.
If you look at the muscles also, you'll see that on the right side, the left side on what we're looking at, but if you look at the muscles, that hip, the right hip has been a problem much longer than the left.
Good.
As I was saying, that's how you may have not known about the left hip problem, but the right hip has been a problem for a long time.
Yeah, and this is another reasons why I like the two large field of view coronal images, because especially if we're dealing with AVN like you're talking about, it's so common to have it on the opposite side, and knowing that when it's still early could be helpful for patient management. So, yeah,
Yeah, the surgeon really wants to know that. You don't want to operate on one hip and then not be able to ambulate the patient. So
yeah. And then if we do the PD fat set, you can see the extensive bone edema here, the flattening due to the subchondral collapse, and we can see the double line sign on the left side. Okay.
All right. So again, it looks like we have osteonecrosis of the hips in varying stages, more progressed on the left. Looks like there's some subchondral fracture. A lot of vertiginous low signal.
In this case, this is a stir. We can see that there's a lot of edema here on the left. Also on the
Very
right.
early
Maybe
on
a
the
coxa vara here as well. And then in the early days of 3T, we started using 3T, and again, asymmetric but bilateral AVN. Again, on the fat suppressed images, we can see the typical appearance of the double line side. Okay.
Yeah, so looking, I mean, the femoral necks look very thin, but I'm not sure I see anything in the heads here.
Yeah, I agree. About 2 months later, we got an MR scan. Here are the sagittal images on the MR scan.
Right. I mean, this looks like degenerative subchondral cysts.
Yeah, and this turned out to be stage 5 AVN. And it's, maybe a lot of things happened in those 2 months, but it was pretty shocking when we saw the difference between the MR and the X-rays. And I've seen that a number of times. So X-rays are just not adequate in evaluating this disease. Okay, and then here we go on, and here we can see the right side. We have AVN here. On the left side, we have a Steinberg stage 6 with marked deformity and destruction of the femoral head due to AVN. Robert.
All right, so we have a 5-year-old with hip pain. Looking at that left hip, there's irregularity of the epiphyseal there.
Okay. There we go. We can see marked underdevelopment of the epiphysis. The T1 weighted image, we can see loss of the normal fat that you should have in that area. And very abnormal. And this is called Legg Calve Perthes disease, which I'm sure you're all familiar with, but it's basically AVN of the femoral epiphysis. So that's at age 5. Tayson, here's age 9.
Same patient?
No, this is a different patient. John, did you have something you wanted to say?
No, I'm just kind of close to the computer, and my ears are listening. So maybe I'm breathing on that.
All right, so again, we have some abnormality of the right epiphysis. Looks like the growth plate has some increased signal in it, and
Effusion.
yeah.
Also intensity on the PD fan side. And this is Legg Calve Perthes disease in a little older individual.
Okay.
I may say something now, but
yes,
when a child is born, what you look for is congenital dislocated hip up to the age of 9 or thereabouts, and that's when you get AVN. Then when you get to teenage years, like 12, 13, and so on, you get subcapital epiphyses. And then when you get to adulthood, then we're talking about AVN again. But usually self-caused or something from the genetic makeup. So when you look at age, you can pretty much center yourself on what the condition may be in that area. you don't get a slip capital epiphysis at birth. That's extremely, extremely rare, I would think. I've never seen a case. Then AVN and so on. You don't see that in a child 2 or 3 years old.
Okay.
So etc. I'll stop there, John.
Thanks. Okay.
Okay, 21-year-old Perthes as a child, no symptoms since age 15 until 2 weeks ago. So the left hip joint, there's deformity of where the epiphysis should have been. It looks flattened. There's remodeling of these acetabulum.
Good.
This looks very chronic, though, right?
It is, because the patient had this disease as a child and has had it the whole time.
Right.
And it's this chronic remodeling you get from the deformity from the Perthes disease.
It's possible this may be some kind of a syndrome.
I don't know. I mean, it's just, I think this is just a sequela you get of Legg Calve Perthes disease and its natural progression.
Yeah, you may be right, John, but I'm a little suspicious on this one.
Okay. So here's a question that was raised. Can effusion or synovitis measured on ultrasound and MRI predict response to intra-articular steroid injections in hip osteoarthritis? What do you think the answer to this is, Robert?
I mean, I would think so, but the fact that you're asking the question probably means it doesn't correlate.
Okay. So they looked at this, and MRI and ultrasound were highly correlated with each other's, but whether you have effusion or not did not really correlate with outcome from injections. And it's generally felt that in this paper they thought that the actual patient's response to steroid injections, which they do, may not actually be related to the anti-inflammatory effects of the steroids. Payson, what is the value of steroid injections in patients with osteoarthritis-related hip pain? This is not, I don't know why I put these questions here.
Osteoarthritis-related hip pain. I mean, commonly done, maybe not as useful as, yeah.
So here they actually looked at patient outcomes in both the short and long-term follow-ups up to 6 months after hip injections. And wait, let me see, hold it here.
On personal note, I don't think that steroids have a place in degenerative disease of the hip.
Yeah. And that's what this showed, that they said no significant change in patient-reported outcomes in short and long-term intervals. I've known some people who felt that they were cured by injections. We also know that some anesthetics are actually toxic to articular cartilage, so you have to be very careful which anesthetic you use if you do.
I'm a pretty good example of that. I had an overdose.
Yeah.
And wound up with a total hip replacement.
What is the value of steroid injections in patients with osteoarthritis-related hip pain? So this is another study where they looked at osteoarthritis, and they did a systematic review of the literature, and they basically felt that steroid injections really didn't seem to be overall that positive, somewhat positive, but there were complications, and the benefits may not outweigh the risks. Are patients more likely to have hip osteoarthritis progression and femoral head collapse after hip steroid anesthesia injections? So this is a very controversial paper where they followed people after injections, and Elior, what do you think the answer to this is?
Sure. I think I've heard that it progresses the loss of cartilage, right?
So in this particular paper, they found that those patients who got steroid injections with anesthesia were more likely to demonstrate progression of osteoarthritis and femoral head collapse than the control group when they had up to a 1 year follow-up. And this is what led to people realizing and then doing other studies to show that some anesthetic agents are actually chondrotoxic. So you have to be careful. I think there are other anesthetic agents which aren't, which may be safer to use. And I don't.
There are different steroids, and that's one of the things to consider. Some are very long acting, and some are very short acting. So,
Yeah.
if you can do a short acting one, to see whether it's more of a diagnostic kind of a situation, that probably is okay. But I don't think about the long acting ones.
Okay. So the other question is, how well do X-ray and MRI grading of the severity of hip arthritis compare to pathology? So they looked at grading on the size of osteophytes, joint space narrowing, and so forth. And what they found is radiologic findings were a reliable indicator of the severity of osteoarthritis when you compare it to pathology. Okay, well, why don't we stop here and we'll move on to our next topic on hip next week. Okay.
All right.
Thanks.
Well, have a good weekend, everybody.
Thank you.
You too. Thank you.
Take care, John.
Thanks, John. Have a good weekend.